basic type guy, so I will go back to basics. I was going to speak about the history of the PCPU, but we'll leave that for some other time. It's going back too far and trying to remember all the little changes that took place. So no, what I thought, you've talked about Fontan, apparently in the past. I thought I'd work my way up there and start at ground zero and work forward. And I'll ask you a question. And this is a discussion. I like discussions. Why don't hypoplasts do well? What's wrong with a hypoplast? Why do they get in trouble? Ultimately we know they die because they don't have a patent ductus. What would happen if you didn't do anything, just kept the ductus open? What if it didn't close? What would happen to a hypoplastic left heart? Would they die? We all die. So, yes, they would die. But how long? I'll tell you, how long do you think the longest hypoplast has sat around, knowing it was a hypoplast at birth?
2 weeks. That's what I was going to say.
What?
2 weeks.
No?
There's adults with half a heart somewhere in the world. I've heard that before.
No, there are somebody out there with it. But I'll tell you, what was the prognosis? When I started here, what was the prognosis for hypoplastic left heart? Do you have any idea? They all died. There was nothing to do. In fact, it was very simple in the old days. You'd make the diagnosis. We did make it by echo. You could try and make it by echo, but echo wasn't very good back in the old days. So we used to cath every one of them. In fact, we used to cath almost every child that had anything that we had no 100% idea what they had. So everybody got a cath in the old days. So in the middle of the night, we'd come running in. We'd have a UAC or UVC in. We'd push the UAC up as high as we could. Boom! Shove in a little contrast. And as soon as we saw that little tiny aorta, we'd say, okay, that's it. Thank you. Leave the cath lab and take the child back to the unit or to the floor usually. And it used to be 5 West. That was the floor starting in 1977. And you'd go to the family and say, I'm sorry, there's nothing we can do, your child's going to die. They said, when the child's going to die? Well, you'd say, we aren't actually sure, but we think in the next several days. But patent ductuses stay open for 2 weeks quite frequently, so it was not unusual for those children to last 7 days, and quite frequently we'd have to say, well, you've been here for a week. We don't know when this is going to occur. We know your child's going to die. You might have to take your child home. We send the child home. And usually they would die within about 2 weeks. And they die because the patent ductus would close. And when it closed, they'd have no cardiac output to their body. They'd have plenty to their lungs, but nothing to their body. And then they die. Well, they didn't always die. They could go home, and in very, I wouldn't say rare cases, it's probably 1 out of 30 cases of hypoplasia, and there are quite a few hypoplasts around. It's actually half as common as the most common congenital heart lesion. VSD is about 15% of cardiac lesions. Most of them don't have any problem. They just tiny VSD, thank you, you go home, and you find you never have surgery. Hypoplasia is about 7% of cardiac lesions, so it's a very high percentage, like 2,500 born in the United States every year, hypoplasia. So we used to send them home, and they'd stay at home, and they'd be there, and they'd breathe fast because they had a lot of blood flow to their lungs. They were, quote, over-circulated. Everybody's over-circulated. So they'd be over-circulated, but then they become less over-circulated. And why would they become less over-circulated? What determines how much blood goes to your lungs? Pulmonary what?
Pulmonary vascular resistance.
Pulmonary vascular resistance. So when you're born, your resistances are high. So hypoplastic day 1 of life is great. Day 2 of life can be great. But as that resistance falls, more and more blood goes to the lungs, less goes through the ductus to the body. Lots going to the lungs. Then they get into trouble, so they breathe fast, but they don't necessarily die from that. They just breathe fast. Then as they live for a while longer, that pulmonary resistance comes back, and they start clamping the pulmonary arteries down. Like any child with a large left or right shunt, if you did nothing about a large VSD over time, many of them would reverse their resistances, get higher pressures in their lung, not higher resistance in their lungs, and then start turning blue because they were shunting blood away from their lungs. They wouldn't be in heart failure anymore. Oh, they it's fine. My lungs don't have any flow, I don't have to breathe fast. And they might even be nice, sort of balanced pink, because just enough going to lungs is going to the body. But they go home, and after about 4 weeks, they start looking better than the families, if the ductus didn't close. And after 2 months, they'd just be sitting there. You know, and the families always said, well, isn't there something we can do? They'd always call us back. And I always told them, don't come here. Because the reason that child's doing so well at home is he's coddled. Nobody comes in and takes his temperature at 3 in the morning. Nobody wakes him up. Nobody does anything. He's not handled by anybody except the family. They just patting the child, make the child nice, do everything nice for the child. Don't upset him. We finally say, okay, if you really want that, you'll have to come down. And this is about the time Norwood started doing surgeries. He had like a survival of 1 out of 10. So 9 would die. So after in 1979, 1980, you'd start saying, well, there is this guy in Boston who, might consider if we show him information and you live 4 months, so they'd come down and they'd come in the hospital. And after that happening about 8 times, I would tell the family, yes, you can come down, but prepare your child's going to die 24 hours after coming in the hospital, because that's usually what happens. They come in, they come all the way down, they drive down from Petoskey or wherever they'd been for 4 months with their child with heart disease at home. They come down here, come into the hospital, and they all would go away because you're in the hospital now. Somebody's got to come and check. We got to check his heart rate. You got to check his sat. In the old days, it was ear things. You come and clip on their ears and things that unstabilize the child. Boom, they die. So it was almost a given. But very rarely you'd have one that would live 6 months. And then you really thought about, they really wanted something done, you'd send them to Boston, or would operate on them. Occasionally they'd live to come back, and then 2 or 3 weeks after they came home, they died. Because again, they were hypoplasts, and hypoplasts tend to want to die after a while for some reason. And so Norwood, what do we do? What do we do good when one does a, quote, Norwood or a Cinena? What's the only thing we change about that child? One thing about surgery is surgery is terrible. In order to get through surgery, you have to do a lot of good for all the bad you do. So you have to come out with something that's a lot better than you went in with, or it's not worth doing, because you beat the child up for no reason unless you change them. What does a Norwood do that changes a hypoplast? What does a Norwood do? You take a child, you got a hypoplast, thank you, pretty normal to me. I can never fault a pediatrician who doesn't pick up a hypoplast at day 1 of life, because I've seen 1 million of them come in here, and we know what they have, and I look at them and say, I don't know what you got. I listen to you, I don't hear much. I look at you, your stat's 92. You're sitting there smiling at me, that as long as we don't put you on aminophylline and stuff like that, you breathe fast because of that. But, you can't tell at day 1 or 2 or 3 that somebody really has hypoplastic left heart by exam. That's why a lot of them used to go home and they die and they come back being resuscitated. They were hardened up, sort of, and they come back, and then that's when you knew they had it. But in the old days, now we know it because you have fetal echo or something else. It's rare for them to walk in the door after going home, but it still happens. So you come in the hypoplast, what side of their heart's doing all the work?
The right.
The right side, okay? It's pumping where? The right side is pumping where? To where?
To the lungs.
And where else? You got no left side.
To the body too.
To the body. So the right side is pumping both to the body and to the lungs. So it's doing double work. And if you let it keep doing double work, the right side doesn't like that. There's a rule of thumb about the right ventricle. It can do pressure work or it can do volume work, but it can't do both. So you can have a right ventricle that's your systemic ventricle, as long as it doesn't do any extra work. Or you can have a right ventricle that pumps a big shunt like an ASD. And they can do great. ASDs walk around, they can play soccer, they do everything. But they don't have a pressure load on them. But if you put a volume and pressure load on the right ventricle, it doesn't like it. So here you have a hypoplast who's got a right ventricle who's pumping to the body and to the lungs, double work. What does a Norwood do for that? after we do the Norwood, or, yeah, something like that, where does the right ventricle have to pump?
I don't know.
Yeah, where do they do it in Norwood?
She's in orientation.
Okay, well, that's fine, well, you'll learn about it. Yeah.
It pumps a bunch to the body and there's only a little blood squirting across the
A
lungs.
little blood going to the lungs?
After Norwood, right?
After Norwood, you're pumping both to the body and to the lungs still. So all you do is sort of make the body for sure get some blood, or at least you hope so, by creating something that's like a big ductus. And at the same time, trying to cut down somewhat on the volume. Now, the big error with the early Norwoods is, what did our surgeons, what most people think your PO2 should be? What's a fairly good PO2? Respiratory therapy would tell you
80 or more.
you gotta have a high PO2. That's normal in life. That's what you're SAT 76. I just was in the ER with somebody with a SAT 76. It was an emergency. You know, I'm thinking 76. That's pretty good. So we have a skewed view of what your SAT should be. But the normal world believes you should have a SAT of 95%. And if you don't, oh my God, we gotta do something. We gotta get more oxygen. Oh, do this, do that. So the world goes crazy. Now, if you have strictly lung disease, that might be the case, but we have a combined thing. So back in the old days, we used to pick a PO2. What do you think the PO2, are you oriented? That's okay. What's a good PO2 for any one of our patients? Any one of our patients. I don't care what they have.
40.
30.
Greater than 30, yeah.
PO2?
Yeah.
I said any of our patients, which includes hypoplasts, includes TETs, includes VSDs, includes anybody. We have a perfect blood gas that we want to see.
40, 40, 40.
740, PCO2 of 40, PO2 of 40, you know, and a lactate that's 1.5 maybe. Anything that's 40, 40, 40, I would never yell at anybody for trying to get to that. You know, even if you're pink, 40 is good enough as far as I'm concerned without beating you too much. So if you can have a 740, 40, 40, that's great. So we used to actually look for a PO2 of around 40 after a Norwood. The trouble was, that was too good. Because the PO2 of 40 meant you had a SAT of what? About?
70?
85.
80s.
What?
85.
85 to 90. PO2s of 40 will give you a SAT that's 85 or 90. What's the perfect SAT for one of our blue patients? Perfect SAT
Perfect.
for a shunted patient.
65.
Well, wait a second. I won't argue with that. But if I had to say, I have a patient out 2 years after surgery, he comes back and I say, you're a shunted patient. I see this SAT. I'm pretty happy with it.
75.
Over 75.
Why 75? Most of our lesions are what we call fully mixed lesions. So that blood comes back from the body and from the lungs, gets together, and then gets pumped back out from the heart, usually going to the body and to the lungs. So in order to have a SAT of 75%, what is the saturation of blood usually coming back from your lungs if they're normal? All that pulmonary blood flow, what's the saturation? In your pulmonary veins, coming back from the lungs, good lungs,
As high as possible.
100%. So you got, 99, it's never 100, but 100%. So you got 100% blood pumping. What's your mixed venous saturation of blood coming back from your brain to your heart?
It's about 60.
What? That's not so good.
75.
Oh, 75.
Yes, the normal human, in order to survive, subtracts or extracts about 25% of the oxygen in their system. So when you're pumping blood out, you're going to say 100%, okay, 100%. It goes out to your feet. And your body takes about 25% of that out, as long as the amount of blood getting there is a normal amount. So a normal cardiac output, you will subtract 25%. If you have less than normal cardiac output, the blood's moving slower, the body will extract more from that blood because it's not getting it. I need this much oxygen. You're running it by slower, it sucks out more. So that somebody with very low cardiac output might have a 60 or a 50, or in some cases, in these children, you might find a 35. But you like to extract 25%, 25%. So your mixed venous sat is 75, 100% out, 75 coming back. Well, if I took somebody who's got a fully mixed system and say, if I give you a sat of 75 in your arteries, and you take 25% out, what's the
50's left.
50% coming back? So if I say, well, we're gonna pump one part of blood to your body with a sat of 75, and we're gonna pump one part of blood to your lungs with a sat of 75, that one part going to the lungs will come back with a sat of what?
100.
100. And that one part going to the body with a sat of 75 will come back with a sat of, and you mix those two together, 100% of one, 50% of one. What's your sat? 75. So when you have equal amount of blood going to your body and your lungs, you're sat 75, which in a newborn gives you really a PO2 of 30 something. It might be 35, 33. But we used to look for that PO2 of 40. So the surgeons used to be in the OR, they'd be doing their Norwood, they'd put their shunt in, and they'd get their first gas, and the PO2 would be 32. Oh my God, it's too low. Or it'd be 29. Oh my God, it's too low. Bigger shunt. Gotta get more blood going to the lungs. But what happens in the OR to everybody we send to the OR? Which organ takes the biggest hit? Which organ takes the biggest hit during surgery?
I would vote kidneys.
Nah.
No?
Well, that's if you're in the heart lung, but not kidneys. Which organ really takes the biggest hit? What do anesthesiologists love to give you in the OR? Fluid. The lungs take the biggest hit. So almost everybody going to the OR who's got lung disease is in trouble to start with. But they get lung disease in the OR. Lacks of fluids, the heart-lung machine, all the, that goes through that. All that stirs up all this inflammatory stuff. So your lungs are bad when you're coming out of the OR. So they're sitting there saying, well, we only got a PO28. Oh my God, we got to get a bigger shunt. They put more blood into the lungs, and the heart comes back, and it says, yeah, my lungs are shot, but in order to get a sat of 80, which you want, I got to pump 4 times as much blood to my lungs, and I'm trying to get one part of the body. You get me 4 times of this, one part there. What hell good did you do me during the surgery? And they'd be pumping. The right heart would say, wait a second, I wasn't pumping good. I had a sat of like 85, but I was only pumping like 2 parts of the lungs and 1 part of the body. And I asked me to do 4 parts of the lungs and 1 part of the kid. With them, and then as the lungs got better, what happened? So they come back with a PO2 of, now it was 35 because they put a 5mm shunt in, or even a 4mm shunt would be 35 when they came back on. That's very smiling. About 6 hours later when they start getting rid of some fluid and their lungs start getting better, the sat's up to, the PO2's up to 40, 45, oh my God. And then, the right heart just says, that's it, I give up. And it would quit. So it was not unusual to come back and they'd come back with a PO2 with perfect. Oh yes, your PO2 is perfect. But the right heart had to do so much work in order to get them the PO2 they wanted. The patients died after. So it was only after the surgeons started having the guts to come back with PO2s that were terrible. And they started putting in 3-5 shunts. They found, well, let's put a 3 in. Well, 3 shunts, there's a certain critical closing pressure. You make a 3 shunt, for whatever reason, they don't stay open. You put a 4 shunt in it, it's too big. So finally they made a 3.5mm shunt. But there was a problem with that even. Back in the 80s, you said, well, we're going to do this surgery on you. Well, what the hell are we going to do 6 months from now or 3 months from now when you're too blue again? So there was always this, we're going to have to reshunt you. We'll have to put a 5 in, and oh my God. So you just went through this same thing. It wasn't only after somebody said, wait a second. After about 6 months, we can just go to a Glenn, a bidirectional Glenn. That was developed in the sort of mid-80s, about 84, 85. Even though Glenn shunts had been done for years beforehand, they were done a different way, and they knew they could work on an older patient. But then they finally decided, well, we can put this tiny shunt in, and then after you get too blue, we won't have to shunt you again. We can do this other thing, and oh my God, that was an epiphany. So they started coming back after a 3-5 shunt, and you'd have PO2s of 28 when they walked back. And I was, hey, This is hooray, Hamavacaine's been relieved. You guys don't know the Little Princess, okay. Shirley Temple, no, okay. All right, so they'd come back and they'd have SATs that were like 65, 70, and PO2s of 28, and we'd all be smiling because we knew that PO2 probably would rise over the next couple of hours to days and be 35 at day 2, after their heart has recovered. It has only been doing, 2 parts of the work, 1 part to the lungs or 1.5 parts of the lungs, and 1 to the body in the right ventricle, which had been doing 4 parts of the work beforehand maybe, is now doing 3 parts of the work. So it felt a little better, but not perfect. So again, they were rocky because they weren't perfect. Okay, that right heart was still doing volume and pressure work. So you hadn't made it a heck of a lot better, but you'd done the one thing you could do, which was cut down on the volume work as much as you could and still survive. So I've never worried about a hypoplastic comes back with a PO2 of 22 or 24. What do I worry about? What is the one thing you look at those guys? The PO2s, how do you know if that PO2 is okay or not okay?
Lactate.
Or lactate.
Yeah, lactates are out of, do you know what else causes lactate to go up that we don't think about enough?
Stress. Stress in the body.
Yeah, but you know which has the biggest, puts out the most lactate? If you squeeze somebody's brain, their brain puts out lactate. So when I see somebody with a lactate of 20, but everything else is fine, I think they took a big hit up in the head. It's not, it's just sort of brain, when it dies, it doesn't do too much. Gut, when it dies, you know it. Brain, when it dies, it doesn't do too much other than you just don't open your eyes, But if I see a high lactate without anything else, I worry about brain injury. Whereas lactates are okay, but the one thing I really worry about, if your PO2 is low, is what?
Perfusion?
Huh?
Are you hard to ventilate?
No. pH. If your pH is 7.38, 7.4, and your PO is 22, you're getting enough blood to your body not to be acidotic. Or enough oxygen to your body not to be acidotic. So as long as you're not acidotic, I don't worry about a PO2 of 25. What's your PO2 before you're born? Your best PO2, in utero.
23.
What?
15.
Isn't it 23?
15.
Well, it depends. It's Crowley, you always have to say, it depends. Where are you talking about, Crowley? Because blood coming back from the placenta, which is in the vein, the umbilical vein, that's a PO2 of about 35. So that's the best one you'd ever see in a fetus. That comes back, and of course, comes up from the IVC, comes in the right atrium and mixes with blood coming back from the SVC. So that 35 immediately is diluted by, that SAT is like, in a fetus is only like 70. It's lower, actually, because they hang on to, their SATs are low, but they can hang on to more oxygen than low SAT. So, they're pumping probably not even, do you know how much blood goes to the lungs in a fetus? What % of their cardiac output?
0.
Nothing.
7%. The lungs, of course, are collapsed in utero. So amazing. That blood comes back, and it's got a PO2 of 35. Where does it go? Coming back from the IVC, where does that blood go? It comes up and it strikes something in the right atrium called the eustachian valve. You ever hear that? There's more valves in the tricuspid and mitral and pulmonary and aortic. There are valves inside the heart. There's something called the eustachian valve, which is like a hood over the IVC. And as the blood comes up, it hits that hood and is directed towards the atrial septum, where your foramen is. So that blood with a PO2 of 35 comes up and strikes the atrial septum, pushes its way into the left side of the heart, and goes to the most important organ of the body. What's the most important organ of the body?
The brain.
Wrong. It's the heart. The heart. You don't have no heart, you got no brain. So the heart actually uses the most oxygen per gram of tissue before you're born than any other organ. It has 3% of the blood flow going to the coronary arteries. So the highest saturated blood comes across the foramen, into the left atrium, left ventricle, out, feeds the heart. Feeds the brain too, but who cares? And then, so the most important, whereas the blood coming from your brain, which has been desaturated, comes and goes across the tricuspid valve, it gets pumped through the ductus down the descending aorta to where the umbilical arteries are that take it to the placenta. So the bluest blood actually doesn't go to your head, it goes to the placenta where it picks up oxygen. So it's a perfectly balanced system. So the body always does what it needs to do, feed the heart first, then the brain, and get the bluest blood going someplace else. So the best PO2 is 35, but that's, you know, it usually isn't that. So your best PO2 in utero is probably somewhere like 26, you know, and quite frequently the PO2 falls into the low 20s to high teens, you know, because your placenta doesn't always work. Like your mom rolls over, put some pressure on something, she doesn't breathe, she's a sleep apnea, whatever. So your PO2 is going like this all the time in utero. So you get a PO2 of 30, that's gravy. Oh my God, that's high. So PO2 of 30 or above is perfectly, is certainly survivable. Whereas PO2s of 22 are probably fine. Now I always have this famous statement. I used to go to South America, and I met this guy there that did tests on, what's about South America? A lot of high mountains. The Incas live at high altitude.
Sure.
So he was studying llamas as far as we're concerned. And he was wondering what the PO2 of a fetal llama is. So he started doing PO2s on fetal llamas that live at 10,000 feet, and it was 5. PO2 of 5. Now, llamas aren't the smartest guys in the world, but a PO2 was a 5 in a fetus would survive very well by llamas. So you don't need a very high PO2 to survive if you're used to it.
So if we get a hypoplast and the PO2 is 5, we're okay with that, right?
And it's a llama, we're in
It
high,
depends.
it's a baby llama.